So the thing that I'm going to discuss today with you guys is deep vein thrombosis, or venous thromboembolism. Involves both clots basically in veins, and when those clots migrate, they are called embolic, and then they end up typically in your heart and lungs, and that's when you get a PE. So these are my disclosures. DVT, or acute lower extremity DVT, is common. You may have it happen in 1 in 1,000 individuals any given year. And then the complications of having a DVT include where it becomes embolic and becomes a pulmonary embolism. You can have recurrent thrombosis, or you can have repeat DVT, as well as post-thrombotic syndrome. Here in the pictures, you can see basically that right leg looks different from the left leg. The left leg looks discolored. It's, slightly swollen. And in the one picture that was coming up was essentially a patient with a PE. And I'm sorry, I'm not able to play that again. But what is post-thrombotic syndrome? So post-thrombotic syndrome is when someone has had a DVT, their veins actually undergo a change because you have an inflammatory response, and then you have scarring, and your valves may be damaged. And now people tend to have this chronic pain condition where they feel fatigued, discomfort, heaviness in their legs. They might have swelling or edema. They could have discoloration. So the leg kind of looks darker, mottled. They have a sensation of heaviness, like I said, and or skin ulceration. And there's a classification system called the SEEP classification system that we use to qualify on what basically which part of the spectrum someone lies on once they develop post-thrombotic syndrome. But what we know is that once you have a DVT, almost 50% of the patients are expected to develop post-thrombotic syndrome. 90% of these patients are unable to work after this diagnosis in 10 years. And over 10% of these patients will develop venous leg ulcers. One of our biggest trials to date that looked at patients with DVT and what should be done for these patients with DVT is called the ATTRACT trial. It was a randomized controlled trial, multi-center. Basically, it had enrolled 692 patients. It ended in 2014, and the patients were followed up for 2 years after. And in this trial, they divided patients with a group receiving just anticoagulation and another group receiving basically something that we offer, which is called catheter-directed thrombectomy or pharmacomechanical thrombectomy. So there are 4 different ways that, we were able to essentially use our catheters to deliver some lytics or blood clot busting medication, and then suck out that clot essentially. And so what this trial looked at is, for a patient with DVT, should we be giving them just anticoagulation medication and sending them home, or should we try and remove some of that clot and then put them on blood thinners, and who does better? And what this trial showed was that there was no difference in whether or not a patient developed post-thrombotic syndrome, even if they had intervention. So the takeaway from this was, overall, there's no difference in post-thrombotic syndrome. So most of the patients should not get catheter-directed treatment as the first-line treatment, that they should get anticoagulation. But then there were several sub-analyses that were done of the patients that had been enrolled in this trial. And in 2017 and 2018, there were 2 separate papers that came out that look at different groups within this randomized control trial. And the group that seemed to benefit the most is someone with iliofemoral DVT. So what we call as proximal DVT. That means that if your pelvic veins are involved, and if you have clot extending into the common femoral vein, then perhaps doing a catheter-directed approach might actually reduce the severity of your post-thrombotic syndrome. And so it did show that these patients recover faster, or back to work faster, and their severity of post-thrombotic syndrome is less. So a couple of things to keep in mind. At this time of ATTRACT trial, we did not have some of the devices that we now have, or some of the technology that we now have to remove all the blood clots, and almost all of them involved giving a little bit of lytic medication, which of course, once you give someone TPA, you see some increase in bleeding issues, whether it's access site bleeding and or internal bleeding. And so now we also understand that clot morphology is different through time. By the time a patient comes in, it may already have been day 2 or 3 that they've realized that they're symptomatic, but it doesn't necessarily correlate to when the clotting process started. So if you look at a clot under the microscope on day 3, it's fibrin rich, and it could, still be broken up by TPA. When you're at day 15 or 21, now you have more collagen, and your clot goes from red to this white appearance when you take it out of a patient. But when you put it on a microscope, when it's mostly collagen, it may not be something that comes out easily, and it doesn't break down with TPA. So there was a study called the Clout Registry, which was done by this company called Inari Medical. And this was the study that essentially got the device, their indication, to be used in the DVT space. And what they saw was what was assumed to be 70% acute clot. When you looked at it, outside of a patient, when you looked at the clot itself, only 33% of it was actually acute. And what was thought to be 8% chronic actually was 32% of those patients had chronic clots. So that just tells us that we don't exactly know at what time the clotting really started, because by the time the patient comes to you, they may have already gotten an ultrasound, they were sent home on anticoagulation, they didn't improve, there's swelling got worse, then they show up to the ER, then the IR consult gets obtained. And so a lot of times, 50% of the time, you might have chronic clot and you may not know it. So now we have some new technology, and there's several, Inari is not the only one to the market. There's several device companies that have treatment options that involve mechanical aspiration of this clot. And these are several papers that basically say that, if you have residual thrombus, which is typically seen after anticoagulation, then you are at a higher risk of having post-thrombotic syndrome. So these papers just show that if you have conservative treatment, which means if you've been treated with anticoagulation alone, 50% of the time you will have some residual vascular obstruction. And when you have residual vascular obstruction, your risk of post-thrombotic syndrome goes up by 2.2 to 3 times over. You have a higher risk of recurrent VTE, you have a higher risk of, if you place a stent in a patient, a higher risk of stent failure, and you may, essentially, like I said, 3 times higher risk of post-thrombotic syndrome. So what is our current algorithm? So someone comes in with a DVT, do all patients need to come to us? No. If they have femoral popliteal calf DVT, they typically just get medical management, right? You typically get a duplex ultrasound, you take a look at the patient. If you think that on the duplex, there might be extension of clot above the common femoral vein, then typically we would request a CT venogram if we really think that there's iliac vein extension, because it can help us plan our course better, or it will help us understand, is there a stent in the patient? Is there a filter in the patient? Is there some reason why they have obstruction of flow? So we identify which segment is involved with ultrasound. Is there a need for a cross-sectional image with contrast? We really need to see imaging with contrast, because that's really going to guide our treatment. And then you get an IR consult, and or we typically get IR consults these days even before we've done all of the evaluation, because the patients are symptomatic. But then when we work up the patient, we kind of talk to them about the risks, benefits of doing a procedure versus just anticoagulation. And now we're seeing all of these patients in clinic actually to basically help them if they do develop post-thrombotic syndrome, because like I said, 50% of the patients with DVT will have PTS, and we're the specialty that knows how to deal with this. So a lot of times they may not need an intervention, but we still could help them. And so we end up seeing these patients. Now, if the patients are going to need a catheter-directed treatment, they typically are placed on a blood thinner immediately. So typically on a heparin drip, we bring them to IR, we stop the heparin drip right before the procedure starts, and then we sort of bolus blood thinners through the procedure. Someone that has a contraindication to receiving blood thinners typically does not do well with any of our clot retrievals. And it's a very rare exception that we will go in and actually treat their DVT if they have absolute contraindication to blood thinners, because we want to keep that blood vessel open. These patients are going to need to be on an anticoagulation regimen. When do you do this procedure? You can typically stage it. You could do it the next day. If they're on a heparin drip, you can kind of do them during the daylight hours. It's only a emergency and needs to be done immediately. If you think that there is threat to the limb, that you are so congested in your venous system that now you're not able to get any arterial blood through. And that's called phlegmasia cerulean dolens, where phlegmasia is pain. Cerulean is when the leg turns blue. And so you have a blue, swollen, painful leg without pulses, and you think that there's risk that they're not going to get enough arterial blood through. That's when you bring them in and do something to basically relieve that clot. Here's a bunch of devices that are on the market that you can use for removal of clot from the venous space. Here's just an example. I'm going to go quickly through this example. A typical patient, 70-year-old male, comes in, 2 days of leg swelling. It turns out he has a compression in his iliac vein that's causing clotting within his left leg. So we typically bring the patient in. The patient's placed prone, so they lie on their belly. We access the lowest point that's open, and or sometimes we have to go through clot. And this is what happened in this patient. We basically popped a needle into the popliteal vein behind the knee. We got our wire up through the clot, and then we use this device called the clot retriever device to essentially pull all of the clot into our sheath. And kind of, as you can see, that sheath has a little area where you can kind of collapse your device and bring the device into and out of the patient. And that's all of the clot that we retrieved. 4 passes and the whole clot was retrieved. And essentially this patient needed a little ballooning of the area to make sure that there was no compression. And I didn't have the perfect stent. I didn't have the perfect size stent for him in order for me to basically open up his lesion. So I decided to let him go on blood thinners and brought him back in 2 weeks. And sure enough, he had clotted his popliteal vein back up. And this time I decided to stick a vein in his calf so that I was able to then balloon the entire segments open. And something that was brought up before in some of the questions that I was given by the medical students was, what is the concept of an open vein theory? So what you want is open to open. You want good blood flow, and you want your pelvic veins to receive blood, because overall that's good for the health of the patient. So you want your iliac vein to have good blood flow. And the only way that's possible is if you get blood through the femoral vein and or the profunda vein. And some of these basically pathways are opened up by just ballooning, because we are currently in our state do not have a stent that goes into the leg vein below the inguinal ligament. So right now, all we have is you can either lyse the clot with catheters left overnight. You can remove the clot, which sometimes is difficult when the caliber of the veins is really small, and or you can keep ballooning and open up the veins so that once you create flow from the calf veins into the pelvic veins, now you have a higher chance that that vein is going to remain open, and the patient absolutely needs to be on a blood thinner through all of this. So that's what was done in this case. And then essentially, as you can see, the image on the right is basically a venogram where now you have good flow through those segments. And actually, this patient was left unstented for a whole year before he started to have some issues with scarring down or narrowing in the vein. And I actually just recently saw him again, ended up stenting that iliac vein, and he has stayed DVT free essentially for now 2 years. Here's another case that's very similar. In this case, you can see in the first image right here, the wires through, there's a whole bunch of clot in the vein. That's why you're not really seeing a whole lot of contrast go through. We don't typically do a whole lot of contrast runs when we already have the information from the CT that there is clot, but we like to identify where the clot is. So you can puff like 5 cc's of contrast just to kind of identify where the clot is, so you can pull it into your catheter. And again, both of these examples are Inari, but there's Penumbra, there is AlphaVac, there are lots of devices that you can use, and even Boston Scientific's Angiojet, which is a rheolytic thrombectomy device, and the way it works is slightly different from just a pure mechanical aspiration. It actually allows you to power pulse TPA into the clot and then suck it into your system. And it works slightly different. And it's called pharmacomechanical thrombectomy or rheolytic thrombectomy. So you can use any of the devices that are at your disposal. A lot of it depends on what's the access, what is the operator experience, whether or not the patient can receive TPA on the table. And then the goal is to remove as much clot as possible and to create flow from your, if not all the way from your calf veins to your pelvic veins, then at least from the femoral vein or the profunda vein into your pelvic veins, and the patient will do okay. A lot of times these patients will come back within 2 weeks to a month, where I kind of stage them, bring them back, make sure the popliteal vein is open and or ballooned so that they don't develop post-thrombotic syndrome. And to be very, very honest, a lot of these patients will need follow-up every couple of years because they do scar down, because that's what veins do. There's a very famous saying, veins don't die, they multiply. And what that means is they usually scar down and your body develops collateral veins. You have all of the perforator veins, you have superficial veins that take over the supply of blood from the leg towards the heart. And these veins are inefficient. And when they present with post-thrombotic syndrome, then it's your duty as their doctor to kind of diagnose them, open up the deep veins. Sometimes closing the superficial veins with ablation strategies might help keep those deep veins open. And, we kind of, like Joji was saying, we see these patients in clinic, they become dependent on us. You develop a relationship with them. You see them typically every 3 to 6 months, and you help. I don't necessarily manage anticoagulation for all of these patients, but I definitely help coordinate hematology input and whether or not they have genetic predisposition. And basically, not only do I help with the procedure, but kind of guide their treatment overall. So hopefully that helps. Sorry if I went over time. If you have any questions, I see lots of stuff going on in the chat. But I'll end there. Thank you for having me. And